Good evening, future flight crew and friends. This is a short video about trauma resuscitation. I wanted to talk to you tonight about a paradigm shift going from our traditional ABC to what the journal Shock calls a circulation first approach, which would be CAB, circulation then airway. So our acronyms are changing from ABC to CAB. And why do we want to do that? So basically the data from the papers and physiologically speaking, we don't want to put airway before resuscitation because we're going to make things worse. If not now, definitely later. So why is that? Well, like they mentioned in this journal Shock, this was with Dr. Chio et al. In January 2023. They remind us that starting positive intrathoracic pressure before we have that hypotension resolved, we're going to reduce venous return even further, which is likely already reduced due to the hypovolemia, due to the hemorrhaging. And then that venous return that is normally boosted by spontaneous respiration, we're going to lose all that boost. Secondly, the paper by Davis et al., and that was in Pre-Hospital Emergency Care in 2022, phrased in another way that might make more sense. That transition or change from spontaneous respirations to positive pressure ventilation is going to lead to hypotension by decreasing venous return and decreasing cardiac output. That increase in that ventilatory pressure is going to lead to the down in venous return. So both of these papers do remind us again that the meds needed for RSI and airway management, those induction meds, can lead to myocardial depression, and then the other meds can make hypotension worse, as the mechanisms can lead to bradycardia, vasodilation, and negative inotropy. Okay, so now that we know why that hypotension is caused and exacerbated by putting airway first, let's talk about what happens because of this. So in 2023, Dr. Breeding et al. Published an article in the American Journal of Emergency Medicine showing that in their review of hypotensive trauma patients, those that got RSI before getting blood compared to the opposite, getting blood and resuscitated before airway, had an increased rate of mortality, and it was 50% versus 78%. And that did have a statistically significant p-value. This was in, I believe, over 1,200 patients that were in this comparison. Further in that paper, they talked about how patients who had post-intubation hypotension, so maintaining that low blood pressure after they were intubated, also had a higher level of mortality, and that was different by 33.2% versus 19.6%. Okay, lastly, to prove my point, to bring you over to the side of CAB, I'm going to go back to the paper in Shock that examined mortality in 5,000 trauma patients, and they found that the most frequent and associated factor with mortality was post-intubation hypotension, and that put them at an increased risk for cardiac arrest and for death. It was the most important predictor of those factors. It also, the most important predictor of that hypotension or cardiac arrest was a pre-intubation systolic blood pressure of less than 100. So in conclusion, I think we should all change our acronyms in trauma patients, switch it up to CAB, and make sure our patients are resuscitated before we not take their airway, but before we intubate them. Thanks.